So today's topic is endodontic emergencies. So endodontic emergency is defined as any condition leading to an unscheduled visit associated with pain or swelling ensuing from pulpo-periapical pathosis requiring immediate diagnosis and the treatment. If you see what is true emergency is, it is a condition that requires an unscheduled visit with a diagnosis and the treatment at the same time. However, urgency indicates less severe problem which can be rescheduled for the next week. Now we'll see the classification of endodontic emergencies by P. Carrot. So, they are classified as three types. The type 1, that is the pre-treatment, that when the patient comes to the clinicians for the first time with the pain, swelling or injury. The conditions that include in the pre-treatment are the hot tooth, dentinal hypersensitivity, acute reversible pulpitis, acute irreversible pulpitis, acute apical periodontitis, acute periapical abscess, traumatic injury, and the cracked tooth syndrome. Whereas emergency that has occurred during endodontic treatment comes under the intra-treatment condition. In that, if you observe, there are various conditions such as the mid-treatment flare-ups, exposure of the pulp, fracture of the tooth with the recently replaced restoration, and the periodontal treatment, hypochlorite accident, and tissue emphysema. These all comes under the intra-treatment emergency conditions. Coming to the post-endodontic emergencies that occur after the completion of endodontic treatment, that may seen in overextended obturation, under obturation, or the vertical root fracture. And we'll see how do we diagnose the endodontic emergencies. So for this, we need the complete history of the patient along with the clinical examination for the successful management of endodontic emergencies. So this can be done with the history of patient with a subjective and objective with the radiographic examination. Now we'll see the pre-treatment endodontic emergency. The first one in that is the hot tooth, which refers to the painful tooth which requires the immediate pain relief at the first appointment. It is most commonly seen in cases of the irreversible pulpitis, where the pulp tissue has very concentrated sensory nerve supply, particularly in its chamber, and it becomes more difficult to anesthetize a hot tooth. So, in this also, the mandibular molars are more affected when compared to the maxillary molars. And what is the theory behind this hot tooth? That is, tetrodotoxin resistant channels. These are the special channels of the sodium which are present in the C fibers are known as the tetrodotoxin resistant channels. So what happens here is, during inflammation, neuroinflammatory reactions start with the sodium channel expression on the C fibers, which shifts the tetrodotoxin sensitive to the tetrodotoxin resistant stains, which causes the inflammatory hyperalgesia. That's how these are more resistant to the anesthetic than the tetrodotoxin sensitive channels. So, what is the option for this hot tooth? How do we manage that? So, for this, first of all, you have to explain the patient and make the management of the anxiousness of the patient using this verbal sedation or the music or the hypnosis, or use the pre-medication, that is the anti-inflammatory drugs to be taken 1 hour before the treatment. and provide the time gap between the anesthetic injections before starting the procedure. And additional anesthetic or the supplemental injections are necessary to achieve the profound anesthesia, such as the infiltration and the supplemental intraligamentary or the intraosseous injections are most helpful along with the pulpal anesthesia. So here the anesthetic solution to be deposited directly into the cancellous bone around the tooth apices, causing the better relief, so that the intrapulpal also sometimes it is painful which when they are inserted into the sensitive and the inflamed pulp. So these intrapulpal and intraosseous and intraligamentary injections are the supplementary injections given for the hot tooth. Now we'll see the dentinal hypersensitivity. It is defined as a sharp, short pain arising from the exposed dentin in response to the stimuli, typically thermal, chemical, tactile, or osmotic, which cannot be ascribed to any other form of the dental defect or the pathology. So, the dentin here exposed by the two processes, that is, by the loss of covering periodontal structure or by the loss of the enamel. So, the two main principal treatment option is that the plugging of the dentinal tubules to prevent the fluid flow and desensitizing the nerve, making it less responsive to the stimulation. These are the two main principal treatment options for dentinal hypersensitivity. Now we'll discuss about acute reversible pulpitis, which is characterized by the localized inflammation of the pulp by the lowering of threshold stimulation of A delta nerve fibers. Here, it gives a non-lingering responsive to the stimuli. So, the management would be the removal of the cause. So, remove the stimuli, that's how the pulpitis will be subsided. Next, we'll see about the acute irreversible pulpitis. It is an inflammatory process when progressed gives an spontaneous pain and exaggerated response to the hot or the cold that lingers even after the removal of the stimulus. So, for this, the management would be the root canal treatment. So, next we'll see about the acute apical periodontitis. It is an inflammation of the periodontal ligament caused by the tissue damage, usually from the occlusal trauma or the extension of the pulpal pathology. So, here the tooth is maybe seen as it elevated from its socket because of the increase in the fluid pressure in the periodontal ligament. So, there will be a discomfort on biting or chewing, which is sensitive to the percussion. Management for this is that the symptomatic treatment with an occlusal adjustment if required, and whereas for the non-vital tooth, the root canal treatment should be an appropriate treatment option. Now we'll see the acute periapical abscess, which occurs due to severe inflammatory response to the microorganisms and their byproducts which have leached into the periradicular tissues. So, in this, the treatment is biphasic treatment that includes the pulp debridement with incision and the drainage. So, and it should be controlled with post-operative pain NSAIDs which has to be prescribed. And in some cases, with the systemic features, the antibiotic should also be given. Next is the traumatic injury. The main objective of any treatment is that to give an immediate relief of the pain. One may be the luxation injury, the fracture of the crown, or the avulsion of the tooth. The luxation injury The main aim is to relieve the pain and to reposition the dislocated tooth. Whereas in case of the fracture of the root or the crown, check the prognosis of the fracture and give the treatment accordingly. That is, either it is a horizontal or the vertical fracture. If you see the avulsion of the teeth, which means the complete or the total displacement of the tooth out of the socket. So the main aim is to re-implant the and to preserve the maximum number of the periodontal ligament cells and prevent them from drying, since the drying can lose the normal physiology and the morphology. So we have various storage media available to place the traumatized tooth or an avulsed tooth. That is the HBHS solution, that is Hanksbag salt solution, coconut water, milk, green tea, and the egg white. So how do we manage the avulsed tooth? So that if the tooth has been replanted before coming to the dental clinic or it is out of the socket for less than 15 minutes, so rinse the mouth with the water, saline or the chlorhexidine and clean the tooth with the saline to remove the debris. And re-implant the tooth and ask the patient to bite firmly on the gauze piece to stabilize the tooth and place the flexible splint for 7 to 10 days. Whereas in case of the immature tooth, clean the root surface and the socket with the saline and re-implant the tooth with a firm finger pressure and give the flexible splint. Next condition would be an extraoral time is less than 60 minutes and has been kept in a suitable storage media. In such conditions, place it in the Hanksbag salt solution and rinse the socket with the saline to remove the debris and re-implant the tooth with giving a flexible splint for 7 to 10 days. Next, in an immature tooth, soak the tooth in the doxycycline for 5 minutes and clean the socket with the saline and re-implant the tooth gently with a firm pressure and give the flexible splint. If suppose the extraoral time is more than 60 minutes or the presence of the non-viable cells are seen, in such cases remove the periodontal ligament by soaking it in sodium hypochlorite for 10 to 15 minutes. And soak the tooth in 2% stannous fluoride and start the root canal before or after the reimplantation and reimplant the tooth and give the flexible splint. That's how the mature teeth is managed. Whereas in case of the immature tooth, remove the periodontal ligament by soaking it in a sodium hypochlorite for 10 to 15 minutes and soak the tooth in 2% stannous fluoride and start the root canal before or after the reimplantation and reimplant the tooth and give the flexible splint. Now we'll discuss about the cracked tooth syndrome. It is the fracture plane of unknown extent and the direction passing through the tooth structure, which may involve the pulp or the periodontal ligament, resulting in the cracked tooth syndrome. And the treatment would be an urgent care, which involves the immediate reduction of the occlusal contact by selective grinding of the tooth and its antagonist. Next would be the intra-treatment emergencies. If you see in that the mid-treatment flare-ups, it may occur due to the over-instrumentation or inadequate debridement or by the missed canals or hyperocclusion, debris extrusion or by the procedural complications. So the risk factor contributing here are the preoperative pain, the percussion sensitivity and the swelling, and the retreatment with a apprehension and history of allergies. So the prevention is to psychological preparation of the patient with the long-acting anesthetics and complete cleaning and shaping of the root canal. After that, the analgesic should be preferred. And give the reassurance to the patient and adjust the occlusion and never leave the tooth open for the drainage. And recall the patient until the painful symptoms subside. Coming to the recently placed restoration. The recently placed restoration may present pain because of many factors like high restoration, micro leakage, inadequate pulp protection, galvanism due to the dissimilar metals. So, these has to be properly checked for the remaining dentin thickness and placed at least leaving the 2 mm of dentin before placing the restoration. Coming to the periodontal ligament treatment. If suppose the periodontal treatment can result in the exposure of the lateral canal which can communicate with the periodontal ligament space and may cause the pain. So, the periodontal surgeries has to be taken care while doing the procedure. Now we'll see the hypochlorite accident. The hypochlorite accident occurs when the sodium hypochlorite gets extruded beyond the tooth apex. So, it may result in the severe pain, swelling with the profuse bleeding both through the tooth and the interstitial tissues. So, in such cases, immediate aspiration and application of the ice pack should be done, and later on, the infection is due to the tissue destruction, prescribe the antibiotics and analgesics and antihistamines. So, if practically what we'll do is that irrigate the canal with lots and lots of the saline so that the sodium hypochlorite which has been spread into the tissues will be diluted with the salines. So, always irrigate the canal with the swelling and give the home care instructions like cold compression to minimize the pain and swelling followed by the warm compression to encourage the healing. That's how it is managed. Next is the tissue emphysema. It is defined as the collection of the gas or air in the tissue spaces or the facial planes. So, when does this occur? This occurs during the periapical surgery when an air from the erotor is directly exposed towards the soft tissues. So, when the blast of air is directed towards the open root canals to dry them, this complication may occur. So, it may lead to the development of rapid swelling, erythema, and the crepitus, which is the pathognomic sign of the tissue emphysema. So, the antibiotic should be prescribed to prevent the risk and the spread of infection, and application of the moist heat to decrease the swelling, and airway is obstructed. In such cases, the hospitalization of the patient is done. Now we'll see the post-endodontic emergencies. So, following completion of the endodontic treatment, patients may usually complain the pain, especially on chewing. In such conditions, it may be due to the few conditions such as the overextended obturation which may lead to the pain. So, this occurs due to the periapical inflammation which results in the firing of proprioceptive nerve fibers in the periodontal ligament. So, no treatment is necessary until the patient is symptomatic. The under-obturation may be due to the incomplete cleaning and the shaping of the root canals. It may be due to the presence of the viable pulp tissue. And in such cases, retreatment is indicated. And the persistent pain occurs due to the failure of resolution of the inflammation. In such cases also, the retreatment is indicated. Now we'll see the vertical root fracture. So during obturation, it may occur due to the wedging forces of the spreader or the plugger. So It may lead to the fracture of the coronal restoration due to the lack of the ferrule on the remaining tooth structure in case of weakened endodontically treated tooth. So the prognosis of the vertical root fracture is poor, so the teeth generally are indicator for extraction. If you see the how do we manage the post-operation emergencies? In such cases, reassure the patient, prescribe the analgesics, check for the occlusion, and do not go for retreatment until and unless the problem is treatable and the patient is symptomatic. And if you see the drugs which are used for the prescription is that for the mild pain, that is ibuprofen 200 to 400 mg, or the paracetamol with the 650 to 100 mg is prescribed. Even after the prescription of these drugs, there is an inadequate pain relief. In such conditions, the ibuprofen with 400 to 600 mg with the narcotic drug combinations, that is 60 mg of codeine, is prescribed. If suppose there is an more pain, that is a severe pain, in such cases with the ibuprofen and the paracetamol, the narcotic or the non-narcotic drug equivalent to the 10 mg of oxycodone should be prescribed. So this is brief about the endodontic emergencies.